All right, well, I have the pleasure of introducing our next speaker. We're going to shift gears a little bit. Over the past couple of years, we've started to rethink the postpartum period. Dr. Haywood Brown, past president of ACOG, established a task force to look at postpartum care, knowing that many women who have adverse outcomes and have maternal death after delivery, some of those occur after 42 days, and that there may be some windows in the postpartum period that we're missing because patients don't come in for care. We're missing early detection of depression and other interventions that may be helpful for these women. So in May of 2018, the committee opinion was released by ACOG, Optimizing Postpartum Care, and our next speaker is Dr. George Macones, who will be speaking on that topic. Dr. Macones is the chair of the Department of OB-GYN at Washington University and the Mitchell and Elaine Yanow professor in the department. He also serves as the fellowship director for the MFM fellowship at WashU as well. He completed his doctorate in medicine at Jefferson Medical College in 1988 and Master's of Science in Clinical Epidemiology at University of Pennsylvania in 1996. He did his residency in obstetrics and gynecology at Pennsylvania Hospital in 1992 and subsequent fellowships in maternal fetal medicine at Thomas Jefferson in 1994 and clinical epidemiology at the University of Pennsylvania in 1996. On a side note, he was my oral board examiner for MFM. Speaking of that terrifying event before, and I made it.
But I was going to say, was that the first time you took boards, but that would be a terrible thing to say. Sorry. Well, thanks for the nice introduction. Wow, it makes me feel incredibly old. But I'm glad to be here with you all today. So again, thanks for the invitation.
He's working on the slides.
Okay. Well, I think as Pat mentioned, the postpartum visit, I think, is something that has been somewhat ignored over the years. And certainly, back when I was training, as Pat mentioned, back in the late 80s and early 90s, the postpartum visit was really something that was viewed as sort of the end of an episode of health or an episode of care, rather than a sort of a beginning. And if I had to sum up what we're going to be talking about today, it would be just that the focus now should be on looking at a postpartum visit as sort of a new beginning for a woman rather than the end of a pregnancy. And I will say that in MFM, we're probably the worst at that, because when we're done with the pregnancy and delivery is finished, we just hand patients back to their generalist. And I would give Haywood Brown a lot of credit as an MFM for taking this on, because it's probably something that many of us have not focused on in the way that we should, much like preconception care, which I think also has gotten short shrift in the past. So over the next maybe 40 minutes or so, we're going to do a little bit of a whirlwind tour of the new paradigm for postpartum care that Pat alluded to, that was really championed by Haywood Brown. We're going to talk about some of the components of postpartum care in this sort of newish model. And then along the way, maybe a little bit about implementation. And the implementation piece, I think, is complicated because the new guidelines really call for, really a bit more, I don't want to say work, because it's not work because it's taking care of women, but again, doing some additional screening and talking about things that perhaps traditionally we haven't really done. So some things that we're not going to talk about today, fortunately for all of us, we're not going to talk about coding or billing and reimbursement. Those are separate issues that other people can talk about perhaps over a large cocktail later tonight. I know there's been a lot of focus on maternal mortality today, so I'm not going to really get into that at all. Although part of the genesis for the focus on postpartum care was the fact, as Pat alluded to, that a lot of maternal deaths were happening in that period. Certainly we need to be advocates for work and paid leave for our patients, but again, we're not going to get into that too much. How we should train our providers and people in our office we're not going to talk about, or research directions, of which there are many. Okay, so why is it focused? I think I touched on this a little bit already, but postpartum care, I think, had really been ignored in the past. And back when I was training, postpartum care was see if a patient needs a pap smear and talk about contraception, and that was it. But there's a lot more to it than just that, because it sets the stage for a woman's long-term health and well-being, and it's a great opportunity to set up a woman for future health success, if you will. There's also fragmentation between maternal and pediatric care, and I do think that there are some opportunities for collaborations with pediatricians that can help in some areas of postpartum care. We mentioned already that about half of maternal deaths occur postpartum, and lastly, this was really Haywood's major initiative back in 2017. So obviously the postpartum period is very complicated for women. There are multiple changes that are happening that we don't need to get into very much, but obviously there's physical recoverment, there are hormonal changes that are happening pretty quickly that can affect people's health as well. For new moms, especially for first-time moms, learning to take care of a newborn, if you already have kids, trying to balance the care of all of the other kids as well with your partner and family. A lot of challenges: sleep, pain, difficulties with breastfeeding, stress. Again, perhaps exacerbation or new onset mental health issues such as postpartum depression, sexual desire changes, and incontinence all make the postpartum period a very complicated time for a woman and for her family. So in the document that Pat referenced, it's called Optimizing Postpartum Care. It's a committee opinion. It really talks about a new sort of paradigm for how we should be taking care of patients postpartum. And I would add that there's actually a great ACOG Postpartum Toolkit that's available on the website that really has a lot of great information and a lot of great references to documents from ACOG and elsewhere that I think will really be helpful to you as you're thinking about your patients either in the hospital or in your practice. So again, the overarching principle of this sort of redefined postpartum care paradigm is that it's not the end of a medical event, but rather we should view it as the beginning of the rest of a woman's life and a chance to really help them achieve great and improved health. It should be an ongoing process and not just that single 6-week visit that is just very focused on a couple of medical issues. I think I heard someone talking about being patient-centered. That certainly should be a focus of all of us today, to really sort of focus on the individual. People have individual needs, and we need to really pay attention to that. So ideally, in this new model, there would be some contact with the woman at the minimum within the first 3 weeks after delivery. How you do that, I think, can be very individualized. For some patients, that could be a visit. That could be a phone call, that could be having your nurse text or email with the patient. There are a lot of ways, or using your EMR communication system to do that. But some sort of assessment or sort of check-in with a patient at the minimum in the first 3 weeks. And that's new for us. So we don't really, at least we had not traditionally done that. Ongoing care is needed, and then a comprehensive visit no later than 12 weeks post-delivery. And all of those 3 pieces should be individualized. So a patient that you touch base with at 3 weeks may need something between then and when she comes back for her comprehensive visit. And we're going to talk a fair amount about the components of the comprehensive visit in just a couple of minutes. And this slide really sort of points out the old and the new. If you look down at the bottom of the graph, and this is right out of the committee opinion, at the bottom of this is sort of our old model of postpartum care, which essentially is a 6-week postpartum visit for every single woman. It doesn't matter if she had preeclampsia with severe features and choreo and an infection and a PE and was in the hospital for 5 days, or if it's her 3rd baby and she had an uncomplicated vaginal delivery and went home. That's the old model, and even just saying that sounds sort of like a silly plan. And we need to move on from that to what we have up on the top, which is really that focus on an initial contact within the first 3 weeks of delivery, and then ongoing follow-up and a comprehensive visit somewhere between 4 and 12 weeks after delivery. The other piece that we're going to touch on very briefly is what to do with patients with hypertensive disorders of pregnancy. They probably need a little bit closer follow-up than most patients, and we'll talk about that a little bit as well. So one problem that I think we've had traditionally is the fact that a lot of patients didn't come for their postpartum visit. And it's easy to point a finger at the patient, but I actually would turn that finger around and point at ourselves. Patients probably weren't weren't as compliant as we like because there wasn't value for them, other than, again, talking about contraception, and there's much more to it than that. And just look at some of the data. About 80% of women who have commercial insurance actually attend their postpartum visit. 50% of Medicaid patients will come for a postpartum visit. This is some national data. But unfortunately, for the patients who probably need it most, who are the patients who are uninsured or self-pay, we don't really have any data on them, but I am sure that it's much, much lower. The net result of all of that is that we really don't do a great job in helping women be set up for success for their health, and we can do a lot better. What are the reasons for poor attendance? I think there are probably many, and some of these are, I think, opportunities for us to think outside the box about sort of changing how we take care of patients and how we give them access to us as providers. But certainly it can be very inconvenient for a new mom and for a new family. They have lots of competing priorities. I think that third bullet point is really important. They're not sure why they're coming in. It could be like a 2-minute visit, and yeah, that's a waste of time to get in a car and drive for 25 minutes if your doc is just going to say, hey, how are you feeling? Good, you're breastfeeding, no contraception, see you later. That's not a value-added proposition. So we need to do a lot better than that. And I think talking to patients in the prenatal period or in their delivery hospitalization about the purpose of a postpartum visit might help to do that. Previous poor experience with the visit, I think that goes without saying. There can be some bad things that happen that sort of stress people out, that make them not want to see their provider if they had some difficult birth experience. People don't like to be scolded, and one of the things that I think patients can sort of feel scolded about sometimes is breastfeeding decisions, so I think we need to encourage them, but if they decide to go in the other direction, that's probably not very helpful. In big practices, sometimes patients can feel disconnected with their provider. If you have a big group practice of 20 people, they don't know who they're going to be seeing. It might be disincentive as well. And then, again, this sort of framing issue, as I alluded to early, it's not the end of a healthcare event, it's rather the beginning. So I think things that we can be doing to try to help with that, or to really discuss some of the issues that we're going to be focusing on postpartum in the prenatal period. Now, I don't think that means that we need to be beating people up constantly about what they're going to do for contraception after delivery, which I think was discussed a little bit in the last session. But I do think there are things that we should be trying to check in with patients about, even before their delivery hospitalization, just so that they are aware of the kind of things that we're going to be thinking about. Infant feeding, baby blues and emotional health, challenges of parenting, sort of what are some of the postpartum recovery things that are going to come up, long-term management of chronic health conditions that we'll talk about in a bit, and a little bit about pain management, especially now in the days of the issues that we're having with the opioid epidemic. And I think, trying to sort of check some of these off during the prenatal period will really help, moms to think about the importance of their postpartum visit, and hopefully will stimulate a lot of questions from them as well when they come in for that comprehensive visit. So obviously, we have an opportunity to check in with moms after delivery as well. It's a little bit of a tough time, I think, to have a lot of big discussion. They've got a brand new baby, hopefully, in the room with them. They've got a lot of family sort of hovering about. But I think there are some things that we can try to check in with patients about. So I think first is what the postpartum care plan is going to look like. And I think a really important thing is patients need to know who to contact. They need to have sort of a contact number for a doctor's office, or if you have a sort of call center line that's staffed by nurses to talk about postpartum concerns, but they absolutely need to have a point of contact. I think another really important issue is, and again, I sort of alluded to this earlier, is what to do with patients with hypertensive disorders of pregnancy. They sort of fall into their own category. I don't know, for those of you who are clinically focused in the audience, if you're seeing as many postpartum readmissions for preeclampsia as we are. I feel like it's almost an epidemic and something that is just really sort of bogging down our system. And I think part of that is because we don't do a great job managing people's hypertension related to preeclampsia after delivery. So again, I think it's really going to be important to check in with those patients a lot sooner. And this, again, comes right from that ACOG document. So again, for patients who have a hypertensive disorder of pregnancy, you need to be to be seen or checked in with somehow, perhaps a home visit if you have, if your patients have access to that, within 7 to 10 days. And for your patients who have severe hypertension, preeclampsia with severe features, if they required IV meds while they're in the hospital, we should be trying to see them probably physically within 72 hours. So that's a little bit of a different group. So most patients can be sort of checked in with at about 3 weeks. Again, most patients. But we want to see our hypertensives a little bit earlier to hopefully try to manage their hypertension better, hopefully reduce some of the complications that come with hypertension, and hopefully reduce some postpartum admissions for hypertensive disorders. And again, how do we define what a visit is? Again, I think it could be a lot of things. I think office visits are fine if it's convenient for patients. Home health care is great. We have a couple of practice nurses who work in our MFM practice who develop very close relationships to our patients. They'll check in by text and email and all sorts of different communications strategies, hopefully not Facebook or Instagram. So I think there's a lot of different ways you can, be clever and accomplish that. And I think we touched base on that. All right, so let's talk about the comprehensive well woman visit. Again, we're gonna see our hypertensive quickly. All other women should have some contact in about 3 weeks. And then we're going to have really a comprehensive well woman visit that's going to set women up for success in their health, hopefully in the long term. And that should really be a transition point to well woman care. And ideally, we're going to do that between 4 and 12 weeks postpartum. So we're going to go through these like in a little bit of detail, but hopefully not too painful, because I know you're all very aware of this. But this is, by and large, the list that you will see that comes out of the ACOG toolkit for this. So here are a list of things that are potential discussion items during a comprehensive visit. Immunizations, incontinence, pain and sexual function, breastfeeding, reproductive life planning and contraception that I think was discussed very, very well in our last session, depression screening, intimate partner violence, substance abuse, weight and exercise, chronic medical problems, and perhaps a little bit about the management of future pregnancies. So that's a big list. Like, I look at this list and I think about what I mentioned before when I was a resident, pap smear and contraception. This is a lot more for us to cover, but I think there are some clever ways that we can do it. So we're just going to sort of do 1 or 2 slides on each of these just to sort of go over what some of the most salient issues are. So for immunizations, again, it's a great opportunity to sort of review where we are. Immunizations are really important and beneficial to the health of our populations. Again, one of the major foci should be Tdap. Hopefully most of our moms are getting Tdap in the 3rd trimester, really focused on the prevention of pertussis in kids. We also want to try to make sure that families know that all household contacts of the new child and caregivers should also get Tdap. We don't have a great mechanism to give them Tdap in the office, but fortunately you can go to Walgreens or CVS or whatever your local pharmacy is and do it that way if needed. In terms of safety of vaccines, they're all really fine except for smallpox. Sort of any live virus you generally try to avoid, but they're really all fine. People should be vaccinated for the flu as well if they haven't been already vaccinated in flu season. But again, there's a great document, comes from the CDC. It's updated very often on the college website to go over what vaccines are recommended for women, and it's a great time to review that and to make sure that people are up to date. Incontinence, I think, is something that is sort of an uncomfortable topic in a lot of ways, but it's really common, and I think we can do a lot better than we currently do. So there's urinary and fecal incontinence. Urinary incontinence is pretty common. About almost 20 to 40% of women will have some degree of urinary incontinence postpartum. Fortunately, a lot of it resolves sort of spontaneously when there is less inflammation and there's more healing in the area after delivery. But about 10% persists beyond 3 to 6 months. So that's a pretty appreciable fraction of women who are having incontinence. Risk factors, I think many know these risk factors, but vaginal delivery, having a long second stage, older age, increased parity, macrosomia as well are risk factors. And I think that it's something that we should be mentioning to patients and perhaps screening them when they come in. But again, we have to sort of make the effort to ask those questions. Again, we don't need to talk much about diagnosis and treatment, but I think that you're not going to make a diagnosis and recommend treatment unless you ask. And I think that's true for a lot of the things that we're talking about today. At WashU, we decided to actually, that doesn't show up very well, but we actually have a little screening form that we use for our patients, for all of our postpartum patients. This is, again, at their comprehensive visit. This comes from the Pelvic Floor Disorders Network. This is how they screen for incontinence in research studies. It's a very simple series of questions. If anyone answers yes to any of those, then that sort of triggers a more thorough assessment and questioning about what's happening. So again, we decided to do it this way, probably because it helps us to remember a little bit. It's sometimes easy in sort of a busy office session where you have expectations for high productivity to forget things, and this is just a little bit of a trigger for us to try to remember. Fecal incontinence is less common, but is really obviously very concerning. Incidence is a little bit higher than you might think. It's about 10% in postpartum patients. The OASIS is for obstetric anal sphincter injuries. Those occur in about 18% of vaginal deliveries, and that is strongly associated with the development of incontinence. Risk factors are similar to urinary incontinence, in addition, forceps deliveries, and I think that just the bottom line is we have to ask the question. Again, it's something that's a little bit uncomfortable to ask or to talk about, but we need to be sort of fearless when we're talking to our patients, and that's what they expect, and that's what they should, and that's what they want. So I think we just need to ask. Again, we don't need to get into the diagnosis and the differential, but suffice it to say there could be an injury to the perineum that needs to be repaired. People can develop fistulas after delivery. There are a lot of things that we need to be aware of. But again, you're not going to find those things if we don't ask, so we have to ask. And again, we don't have a screening form for this kind of incontinence. I think it's really sort of a one question or two question kind of thing to bring up. Pain, dyspareunia, and sexual function. Again, a lot of women have a lot of pain after delivery that lasts for a long time. Up to 17 to 20% of women have that kind of pain 6 months after delivery. And again, it's a question that we need to ask. Are you having pain with intercourse? And again, a yes response to that should really trigger additional questioning. It should trigger a physical exam. It should trigger sort of looking for causes that we might be able to hopefully improve. Breastfeeding, I would imagine there was some discussion about this in a few sessions today. Again, we don't need to belabor the point too much, but suffice it to say there are incredible health benefits to breastfeeding, and we should all be trying to support our women and encouraging them to breastfeed. And I know that everyone here in this room is is on board with that. We're doing better. About 81% of women in the U.S. at least begin breastfeeding, and about 50% are breastfeeding at about 6 months. So that's much better than we had done in the past. And I wouldn't say our place is doing quite that well. We were recently designated as baby friendly, and that's sort of really helping us to work on that. But again, I do think it's really important. And I think it's important to sort of bring this up at the comprehensive visit to really talk about how breastfeeding is going, and are there issues, and are there resources or things that we can do to help. I think before women start to breastfeed, a very common question, especially for us at MFM, is the medication that I'm taking for my seizure disorder or for my history of a thrombosis safe to take when I'm breastfeeding? And I have a hard time remembering all of those medications, even though I see those patients all the time. I would really encourage you all to grab this app called LactMed. You can just go right to the App Store on your iPhone. I assume it's on the Android store as well. It's really great. You can type in just the generic name or the other name for the drug, and it'll tell you exactly what you need to know that moment for taking care of a patient. I'm not going to talk about contraception because I think the last session really covered that very well with breastfeeding. I would just encourage us all to use lactation consultants liberally, but also, again, this came up in the last session, let's try to make sure we're sort of on the same page with them, because you can definitely get into differences of opinion about different medications to help with breastfeeding and what's the role of estrogen and decreasing breast milk production. And I think to the extent that you can, we want to be on the same page. The worst thing is for patients to get mixed messages about what they should be doing with their health. And I've had that happen a number of times. And they're easily resolved with some face-to-face conversations with other healthcare providers. But again, I would say use your lactation consultants liberally. In fact, in our MFM practice, 2 of our nurses who work for us actually are formal lactation consultants and really help us day to day with that. This came up also in last session. It's really important at this comprehensive visit to talk about the future and what are someone's sort of perhaps short, mid, and longer-term goals for their family size. And I know we talked about that one key question, which I think is really great. Would you like to become pregnant in the next year? I think our last speaker talked about perhaps extending that out, which I think is terrific. That will really sort of set up a good segue into a discussion about different contraceptive methods, which I think have been covered really well, and a little bit about inter-pregnancy interval as well, which is a really important and somewhat under-discussed topic, I think. I'm going to skip that. And I wanted to just show just a little bit of data. I only have a couple of data slides, but this really looks at all of the studies sort of summed up, looking at the relationship between birth spacing and the risk of adverse perinatal outcomes. And this was published in JAMA. This is an older study, but I think still is probably the best out there. It took 67 different studies and sort of put them together, looking at that relationship between the time between pregnancies or actually deliveries, rather, and the risk of increased bad outcomes. And you can see for inter-pregnancy intervals that are less than 6 months, there's an increased risk for almost everything bad that you can imagine. Preterm birth, low birth weight, IUGR, or small for gestational age, and that there was still a risk between 6 and 18 months as well, although the risks were a little bit smaller. So I think avoiding less than 6 months is a good idea. Now, interestingly, there was also an association between the inter-pregnancy interval and some of those outcomes if it was very long as well. That's a little bit complicated because there's probably a lot of reasons why the IPI might be long, might be related to a lot of other health issues that a woman might have. But I think suffice it to say the best information we currently have is that the ideal inter-pregnancy interval is between 18 and 59 months in terms of having an ideal perinatal outcome in the next pregnancy. Just so you know, the way this is being counted, that 18 months means having a conception 9 months after your last delivery. So it's actually from delivery to delivery, if that makes sense. So again, I think birth spacing is important. I think Stacy Stewart is talking tomorrow from March of Dimes. March of Dimes is really looking for some of the things that we can do to impact preterm birth, and inter-pregnancy interval is one of the very few modifiable risk factors to reduce the risk of preterm birth. So again, something really important, I think, to talk about. Postpartum depression, again, I think we all know a lot about this already, but screening for postpartum depression, I think, is very important. It's very common, 11 to 20%. Again, risk factors, I think we probably have a pretty good sense of, but prior history of depression, anxiety, stressful events during the pregnancy, preterm birth, or a baby in the NICU or intensive care nursery, sort of low family social support, and issues with breastfeeding are all risk factors. I think we finally come to a place, I guess probably about 6 or 7 years ago, where ACOG recommended that all women be formally screened for depression. Not just how are you feeling, but actually using a scale that is validated in pregnant women to screen them. And if you go to this postpartum toolkit, or if you go to the ACOG Committee Opinion on Postpartum Depression, they have a list of validated tools. Validated means that they've been researched in that population, and they know that they are screening for what we want them to be screening for. The most common one is EPDS, Edinburgh Postnatal Depression Scale. It's what we use. We actually have it computerized on a little iPad for patients, so when they come into our waiting room, we give them an iPad, and they sort of click through that. It calculates the score to us, which is pretty simple. It's like only goes up to 16, but it helps us. So I think you need to be using a validated tool. We've actually started screening a number of times in pregnancy. So we screen at about 24 weeks. We screen when a patient is in the hospital after delivery, and then we screen them at their comprehensive visit as well. And I think there's a lot of benefit to that. Treatment, I think, is, it could be multifactorial. It depends where you are and what kind of availability you have for, other specialists, but peer counseling, cognitive therapy, antidepressants. I would say when this committee opinion on postpartum depression came out, I was on that committee at ACOG at the time, and as we were writing it, it was clearly the right thing to do, and my initial reaction was, wow, we're going to make all of these diagnoses of depression, and we have no place to send the patients. Like, nobody's going to see them. There aren't enough people doing therapy to take care of them, and I think that really did sort of force our hand as providers to become more comfortable in using antidepressants ourselves. Although I still don't feel totally great about it. I feel good enough to prescribe and get people started. But I do think trying to develop some relationships with health providers, mental health providers in your community is going to be really important because you're going to turn up a lot of positives. But again, I think the key thing about postpartum depression is use a validated tool. Pick one, use it. It doesn't have to be EPDS, although I think that's the most common around the country. I wanted to mention this just as there are some things that we do extremely poorly where I am, and there are some things that we do pretty well. This is one of the things that I think we actually do pretty well. We actually have a health service, a perinatal behavioral health service at WashU. I guess it developed about 8 or 9 years ago and was really the genesis of a pediatric psychiatrist, and as well as some faculty members in my department, who really felt like we were doing a poor job in sort of the mental health needs of our women who were pregnant and had complicated pregnancies. So sort of a group of people got together that included OBs and psychiatry, psychology, social work, and started with moms and families in the NICU. So again, moms who have sick babies in the NICU are at very high risk for a lot of mental health problems. And this group would go and visit with them, a couple of times a week. They prescribed meds for depression, and they really, I think, provided a great service. We then extended that program to our high-risk undelivered patients. A lot of those are moms who have babies that we know have birth defects and are going through a very difficult pregnancy with a lot of uncertainty about how things are going to turn out. That was really successful as well, and we expanded that to really seeing all of our pregnant patients in the hospital after delivery, and then if we think that they need to be seen before delivery, this group sees them as well. They either talk to patients on the phone, they do in-person visits, they have a lot of access, different access points to patients. The problem with a program like this is that it doesn't make any money at all, like literally zero, and it's hard to fund. We were lucky because our hospitals that we work with, Barnes Jewish Hospital and St. Louis Children's, have very substantial charitable foundations, and those foundations love to fund programs that will never be funded by the hospital itself. And they've picked up the tab for this, and I actually think it's been a great service for our patients and has really, really helped them. So I wouldn't say this is necessarily a model program, but I do like the idea of having one group of people who can relate to either a mom antepartum in the hospital or see them after delivery, and perhaps see them through the continuum of those episodes. So that's gone pretty well for us. Intimate partner violence, I would say another thing that most of us do extremely poorly with, and we need to do a lot better because this is really common and is a huge issue for the health of women. And I'm not going to show you a lot of the terrible statistics about this today, but it is really also an epidemic. Physical, sexual, or psychological harm by a current or former partner or spouse, that's the definition. Lifetime risk, believe it or not, is 25%, which is so high it just almost makes me cry to hear that. Women in the military and vets seem to be at increased risk. This is something that we need to be asking about. Again, this comes from the toolkit, and I like some of sort of what's in here, sort of a way to bring up this question, because for some patients it might seem totally out of the blue. So I like this first sort of what they call a framing statement. We started talking to all of our patients about safe and healthy relationships because it can have such a large impact on your health. Talk about confidentiality, and here are just a couple of sample questions that you might ask. As a male provider, it's sometimes a little bit uncomfortable for me to ask these questions. So we actually have divided up labor a little bit in our office. Our practice nurse for our postpartum patients will go on first, and we'll ask some of these questions, which I think is a little bit better because she has a closer relationship than I do to many patients. We have a big group of 16 MFMs, and she knows them all, and I know them all a little bit, some pretty well, but some not so well. And I think that's helped a little bit. I think it makes patients, I hope, it makes patients a little bit more comfortable. But I do think that having some structure around what you're going to say and what you're going to ask is going to help you to talk about something that is just a little bit uncomfortable, and perhaps rightfully so. Substance abuse screening also, an incredibly important issue and something that we need to take on directly. That certainly includes opioids, other drugs, alcohol. Lots of bad things happen to people who are using substances that are illicit or drinking too much, and we need to be doing routine screening as well. Here, this also comes from the toolkit. These are some of the clinical screening tools that you can think about using. 4 Ps, there's a National Institute of Drug Abuse quick screen that you can use. There's one for young adults as well. Again, this is just one of those things like just pick one of these and use it, and it'll be a good trigger, to make sure that you're covering the key things that women really need at this comprehensive visit. I think we underestimate alcohol. I know we're all crazy about opioids right now. And we should be, because we do have a lot of issues, but alcohol abuse is more common than opioid addiction, and it's something that, again, is a place where we can make a real difference for our patients. It's the 3rd leading cause of preventable deaths in women, which is just incredible. Over 55% of non-pregnant women use alcohol within the last 30 days of being surveyed. Prevalence of binge drinking in the last 30 days is 18%. I read the definition of binge drinking to remind myself, and I'd have to go back to my days in college to really be a binge drinker, I think. It's a lot. And I think importantly, how many times have you heard a woman say, oh my God, when I deliver, the first thing I'm going to do is have a bottle of red wine. Like, I hear that all the time from patients, and again, we need to be thinking about that and trying to help women to be maximally responsible for their health when it comes to alcohol use. This is a great little screening method. I like it. It's called taste screening. This was developed by the National Institute for Drug Abuse, I believe. So T is for tolerance. How many drinks does it take for you to feel buzzed? And if it takes more than 2, you get 2 points. Annoyed, have people annoyed you by criticizing your drinking? That's 1 point. C, cut down. I think that's the best question. Have you ever felt like you should cut down on drinking? And then E, eye-opener. Have you ever had a drink first thing to steady nerves or quell a hangover? And that's 1 point. And if you have 2 or more points, it's a positive screen. And regarding the eye-opener, I was just in Cabo, and I did have a breakfast margarita one day, and it does not count because that was for that was for an entirely different reason. But I think it's a great screening method. So keep it in mind. I think again, I like the idea of having formalized screening because it makes you do it, and it makes you think about it, and that's a way that we can make sure that we are doing the right thing for our patients. Same thing for smoking cessation. A lot of people quit when they're pregnant and start again postpartum, and that's not good. And we don't need to have a big lecture about why smoking is bad. Here's a nice screening model, 5 A's, ask, advise, assess, assist, and arrange. It's really fast, just takes a couple of minutes. Anyone can do it. Our nurse, one of our nurses in our practice does this for us as well. And there's a great tobacco use and women's health resource from ACOG. Weight is difficult and complicated. And I think a lot of us sort of feel like there's nothing we have to offer patients, and there's nothing we can do, and we sort of ignore it. But on the whole list of things that we've talked about so far, this might be the most important for a woman's long-term health. And I think it's something that, again, we need to be a little bit more sort of fearless about, and maybe educate ourselves a little bit better, and really sort of take it on directly with women. Third bullet point, I think, is very important. Physical activity in pregnancy is good, and we should be encouraging our patients to exercise during pregnancy because that can help them to carry things on into the postpartum period. And those are the recommendations about exercise that come from national guidelines, essentially 20 to 30 minutes per day of moderate exercise. You know, it used to be that we essentially would tell patients to do nothing exercise-wise for 6 weeks, and I think that's just wrong. There are a lot of patients who should start to exercise pretty quickly after delivery, depending on how their pregnancy and how their delivery went. And this is sort of going back to being patient-centered and trying to individualize things. It's not a cookie cutter. You know, what's right for the woman who had the PE who weighs 400 pounds is not the same thing for the G3 P2 who just had a nice uncomplicated delivery, and we need to be thinking that way. But for people who've had an uncomplicated vaginal delivery, they don't need to wait until 6 weeks, and they can certainly start earlier if things are going well and you've checked in with them already and they're doing well. Certainly for people who have C-sections, they should be back to full activity, hopefully if things are going well by 4 to 6 weeks. And although again, there are some patients who are going to be ready to begin to get started exercising sooner than that. Breastfeeding is obviously fine when you're exercising. You need some additional calories, but at least from what I know of the data, exercise certainly doesn't affect milk production. Some practical advice about talking to weight. Again, I think it's something that's sort of uncomfortable, to bring up. But we need to be more, again, I'm going to use the word fearless and not be afraid to talk about things that might be uncomfortable. Maybe we're a little bit overweight ourselves and, so it makes us a little bit uncomfortable, but we have to do it. So I would say first try to normalize the topic when you talk to patients and don't be looking down at the floor. I think you can talk directly to a patient about what their goals are for the weight. Forget BMI. I wish BMI was never invented because it never makes anybody feel good. There's nothing good feeling about your BMI. So just don't even mention it. Who even thinks in BMI? Patients don't think in BMI. They stand on a scale and look at their weight. So, don't get wrapped up in BMIs. Don't be sort of stress and negative. It's easy to say, oh, you're overweight, you're obese, you're morbidly obese, oh my God, or you're class 4 obesity. Don't say any of that stuff. And maybe focus on things like, let's try to get to a healthy weight for you. And sort of think about things in sort of the glass half full way instead of sort of the glass half empty way. And then I think sort of be reasonable when you're talking about weight. I think sort of a good starting point for a lot of patients is to just talk to them about trying to lose some or all of the weight that they gained during pregnancy. That's achievable. It's crazy to talk to somebody who's 280 pounds and say, wow, you really need to lose about 140 pounds. Yeah, great. Well, let's spend the next 50 years trying to do that. So again, try to be reasonable. I think that's a good place to start. And then, use resources. There are a lot of, there are a lot of resources out there to help people to lose weight: nutritionists, diet, exercise, programs. Don't tell your postpartum patients to go on a keto diet. That's probably not the best thing for them. But there are a lot of programs that I think that can really work well, and behavioral intervention, believe it or not, actually does work. Chronic medical problems, I'm just going to fly through these last couple of slides, but suffice it to say a lot of women who have medical problems that are of great relevance in the postpartum period, and this is something that, obviously as an MFM, something that we deal with all the time. Some get worse in the postpartum period. Things that we think about most commonly are probably multiple sclerosis and rheumatoid arthritis that tend to get better during pregnancy and then get worse. What's important about that is that during the prenatal period, you need to tell patients that and make sure that they have good follow-up in the postpartum period. And that's a good thing to check in with them in that 3-week sort of check-in point to make sure that they've had their appointment with their rheumatologist or with their neurologist to talk about, whether they need to be on new meds or not. So you want to be thinking about that up front. Other medical problems will require rapid changes in medications. So hypothyroid patients tend to need less medication pretty quickly. Diabetics will need less insulin, assuming they're on insulin, pretty quickly as well. The management of hypertension, especially related to preeclampsia, is complicated and requires, I think, a lot of monitoring and assessment, and then a lot of the transplant drugs as well change quickly. So you need to be thinking about that as well. And importantly, there are some some conditions that we may diagnose during pregnancy that we can't treat during pregnancy but can be successfully treated afterwards. Best example now is Hep C, which is a curable condition. We're doing more and more screening for Hep C, and I'm guessing many people at your institutions are doing the same. So it's something to make sure that a patient has good follow-up for. I'm going to skip this for the sake of time, but my slides will be available if you need them. And then lastly, I just wanted to wrap up with, this comprehensive visit is a good time to sort of do a bit of a recap about how the pregnancy went. And if a patient has a plan for a pregnancy, perhaps sometime in the future, to the extent that you can, talk about the things that they can do pre-conception and what a plan might look like for a next pregnancy. So, for example, if someone is at risk for preeclampsia, you can mention baby aspirin to them. It seems to me that in our practice, literally every patient's on baby aspirin. And I could make $1 million if I just put it in a prenatal vitamin. But again, that's something to be thinking about. For our patients, we see a lot of complicated pregnancies, obviously, who have a prior preterm delivery. Again, have a discussion about sort of what the current thinking is about some of those options, 17P, vaginal progesterone or cerclage, or some combination thereof, just to get them thinking not perhaps so much about what the actual therapy is, but rather that there are things that can help them to have an improved pregnancy outcome. And that's very reassuring, I think, to patients. When something bad happens, they think it's going to happen every single time. And I think this is a good opportunity to sort of recap that with them. Hopefully, there aren't many patients having stillbirths, but if that was the case, and certainly reviewing all of the evaluation, this would be a good time to do that, to talk about the future as well. And then in terms of getting ready for a pregnancy, thinking about folic acid supplementation in the preconception period, and then this whole issue of healthy weight and how that can set up a woman for success during pregnancy. So again, this is a lot of work. We went through a list of, I think, 12 things that we need to be working on in our postpartum visits. Compare that to the 2 things that I was focused on when I was younger, so we have more work to do, and with not a lot more time to necessarily do it. So I think we have to really work on efficiency and utilizing as many people as we can to make it all work. So I think being prepared, and this is something that I really try to do, is to look for our postpartum patients that are coming in, to look at what happened during their pregnancy, to review their record, have a little bit of a plan. To me, it's sort of like a new patient. Like when I'm seeing a new patient, I never want to go into the room blind. I want to sort of know why the patient is coming to see an MFM, and I think doing this has helped me for our postpartum patients as well. Engaging women before their visit, I think, is a good idea. Some things that you could do before they walk in the room, you can have them fill out a little form with what their top 3 issues are. Like, that's a good place to start. You get a lot of information. A woman says they're worried about their weight, their breastfeeding, and whatever else. That's a great starting point. You should be able to do their screening for depression in a waiting room as well. You could do it on paper. You could do it on an app. There's a lot of different ways you can do it. Again, sort of focusing on weight, you can ask them in advance what their desired weight is, contraception, et cetera. And as we sort of talked along the way about this, I think trying to optimize your staff is really important. Again, we have our nurses do a good chunk of this work, which sort of allows the physicians and our NPs to be a little bit more efficient. So trying to be clever about how you utilize them and train them appropriately for what you're asking them to do, I think would be helpful as well. So that was really a whirlwind tour of the new guidelines on postpartum care. I think this is a great step forward for the care of women. I just encourage everyone to think about the postpartum visit as not the end, but rather the beginning. And if you look at it in that way, I think we're really going to do a better job for our patients. Thank you.
We're a little bit, thank you, Dr. Macones, that was awesome. We probably have a second for 1 or 2 questions real quick, and then we're going to break for our simulation groups, if there's any questions. Okay.
I like that idea of framing it as not the end, but the beginning. But in a state such as ours, where we haven't expanded Medicaid, for many women with Medicaid, it is the end of their care. And so what we've looked at in our own local community is, and we're working right now with depression screening, is how to make that transition from maternal care to well woman care, how to get them to that next available resources. So I'm just wondering if there's some advice or some thoughts about strategies when, for low-income women, they see it as the end of care, and certainly for providers seeing them, they can do these wonderful things during this short time period. But
Yeah, so we are also Missouri has not expanded Medicaid either, so we certainly have the same issues. Our FQHCs where I work in St. Louis are also receive a lot of charitable funding and are actually able to see a lot of those patients for ongoing care, which I know is not true everywhere, but that's really worked, pretty well for us. It doesn't take care of everything. So the patients that we struggle probably with most are our undocumented patients, which I would imagine is a big problem. Again, I'm guessing is a bigger problem here in Texas. And I honestly don't have a solution for that. But the charitable giving to our FQHCs has really helped us to provide that access to care after they're done with a pregnancy and their Medicaid coverage goes away.
Well, thank you for the questions. If you have more questions for Dr. Macones, come up afterwards. And to keep us on schedule, Dr. Lakey.
Well, first, I want to thank all the speakers and all the moderators today. I think they did a tremendous job going through a lot of complex information. So quick applause for all the moderators and all the speakers that came here today and enlightened us. I think it's been a really good first day, and we're not done yet. And so a couple of quick announcements for the rest of the day. Starting at 5 o'clock, we have our simulations. We have the obstetric simulation in room 103 and the neonatal simulation in room 104. And again, I encourage all that are interested in how you can use high-fidelity mannequins to improve quality improvement in your hospitals, just go and take a look at the simulations in both those rooms. Following that, at 6:15, you're all invited back to this room. And we are again blessed to have Ann Borders to come and have a conversation with us related to maternal quality, AIM bundles, and how we really can implement those with the group of stakeholders here, that many of them that you've already met today. Tomorrow we begin at 8 o'clock. We have several keynote speakers that I'm really excited to hear. Lisa Ollier has joined us, the president of ACOG, and she will be giving us our keynote speech. And also, we're fortunate to have Stacy Stewart, the president of March of Dimes, who will be here and enlighten us related to looking at disparities and how do we address those in the nation. So, and then later in the afternoon, we'll have about an hour to really talk about next year for all the groups and what are the quality improvement collaboratives we're going to be moving forward. So, again, a very exciting day, and thank you for hanging in there, and encourage you to hang in just a little bit more. Take a break, and we'll see you in the simulation rooms at 5, room 203 and 204. Thank you. 103, 104, 103, 104. It's been a long day, folks.